Yes, sir.
Okay, now I'm talking about genitourinary trauma. We already know that 80% of the genitourinary trauma is blunt trauma, right? So blunt trauma is that in which there is no penetrating injury to the organ, right? So very rarely this is life-threatening, and probably because the genitourinary tract is not openly exposed, it's been covered by, like in the pelvis, by pelvic bones, and if you see, look at the kidneys, by the lower thoracic cage. For urethral injuries, we need to assess whether the patient has concomitant pelvic fracture or not, right? So we talk about external genitalia first. Trauma here in females is very rare, obviously because of the short size of the urethra, while in males it is very common, and it's very obvious. We need to look for swelling, ecchymosis, and deformity on clinical examinations. As far as testicular trauma is concerned, a rare variety of testicular torsion can occur in patients who undergo trauma, but the most common is the testicular rupture that occurs in about 50% of patients with a direct blow to the testicle. Uh, we have to be very much sure in diagnosing these patients on clinical grounds, because ultrasound is not a very good modality to pick up testicular ruptures. We need to see on the basis of history, and we need to see the pain scale of the patient, and then on examination we need to see the swelling. These are the points which make us to come to a conclusion that the patient probably has testicular rupture rather than relying on the ultrasounds. Penile fracture is a very rare variety which we as urologists come across, and it is secondary to sexual accident. And the patient usually presents with pain and a popping sound which the patient hears himself. So if you look at this diagram, you can see in the center, the upper diagram in the, sorry, the upper diagram in the center, you can see the corpora cavernosa, and surrounding the corpora cavernosa is the tunica albuginea. So basically there is a rupture of the tunica albuginea which produces this pelvic fracture. So 20% of these pelvic fractures can be associated with urethral injury, and that is if the corporal trauma occurs on the ventral aspect of the penis. If you go back to your anatomy, you know that urethra is on the ventral aspect. So if it is associated, the rupture is associated on the ventral aspect, then can be associated with urethral injury. But urethral injury patients usually present with blood at the meatus. So all these injuries, whether it be urethral injury or there is penile fracture, that usually requires certain operative repair, and that should be done within 24 hours, so to avoid unnecessary fibrosis. And if that is repaired within 24 hours, that has a very good outcome. So this is the deformity. It's basically called the eggplant deformity. Penile fractures usually present with this type of swelling. Now we come to a urethral injury, which is very common. Again, this is very rare in females, probably because of the short urethra. While in males, it is divided into anterior and posterior urethra, divided by the urogenital diaphragm. You already know from your anatomy that urogenital diaphragm is the one. I cannot actually have an arrow here, but it's basically the prostatic urethra and the membranous urethra, which is occupied by the urogenital diaphragm, constitute the posterior urethra, and anterior urethra is the one which is in the perineum, and the whole of the penile urethra is the anterior urethra. So in males, that is divided into anterior urethral injuries and posterior urethral injuries. In males, 25% of all pelvic fractures have urethral injuries, more commonly the posterior division. So any patient who presents with pelvic fracture, we need to be sure and we need to confirm this. Probably he might be suffering from a urethral trauma. So the most common sign of which tell us that probably the patient has urethral trauma is the hematuria. So a patient with gross hematuria and pelvic fracture. So we need to suspect a posterior urethral injury until proven otherwise. So there are certain clues to urethral injuries, which are blood at the meatus, gross hematuria, inability to void, and ecchymosis and swelling of the penis. So in a patient with pelvic fracture, we need to see all these things before we jump on to pass a Foley catheter in trauma patients. So what four things are necessary before we attempt to pass a Foley catheter in a patient with pelvic fracture? No pelvic or suprapubic tenderness. If there is no tenderness, then we can obviously attempt to pass a catheter. No penile, scrotal or perineal hematoma, no blood at the urethral meatus, and no abnormal findings on DRE. So I'll just discuss shortly what findings are there on DRE. So these are basically four things which we need to see, that there should be no pelvic or suprapubic tenderness, no swelling in the external genitalia region, no blood at the meatus, and no abnormal finding on DRE. Then we can easily pass a Foley catheter in these patients with trauma having pelvic fracture. High riding prostate is basically one of the diagnostic feature of posterior urethral injury. So what is high riding prostate? It's basically the prostate is lifted upwards. So you can assess this on the basis of digital rectal examination. If you do a digital rectal examination, you can easily feel the prostate just above the pubic bones, pubic symphysis. And if it is not felt, it is felt a higher up with associated pelvic fracture, then you should always suspect a urethral injury, especially the posterior urethral injury we are talking about. If there is any concern for a urethral injury, we can easily do an X-ray retrograde urethrogram. So this is an X-ray which is done in the X-ray department. What we do is we insert a small feeding tube down the meatus, roughly around 1 to 2 centimeter through the meatus, and then we inject a contrast into it and outline the whole of the anterior and posterior urethra. So I'll just show you the diagram of this. So retrograde urethrogram either can be normal or there can be partial urethral injury. Partial urethral injury means that some dye is going into the bladder and there is some sort of extravasation from the site of urethral injury. And there can be complete urethral injury, that there is no dye that is going into the bladder. You can see this diagram, and you can see this white line. White is the urethra, that is the contrast going down the urethra, and there is extravasation of contrast in the posterior urethra, and above that you can see the pelvic bones. So this is the X-ray urethrogram that is done in the emergency setup, when we are not sure and we need to have a correct picture of urethral injury. How do we manage urethral injury? Right. If you have no concern for injury or retrograde urethrogram is normal, you can easily put in a Foley catheter. If it goes easily into the bladder and the clear urine come out, you should be very much sure that there is no urethral or bladder injury. If there is a partial tear, usually there are two school of thoughts. Some people say that you should do a gentle attempt of 12 or 14 FR Foley catheter. And if it goes, then it means that there's no much of an injury and you can just leave the Foley catheter for a week. While if there is a complete tear, you should not attempt a Foley catheter, and in that setting, suprapubic catheter should be passed. Suprapubic catheter sometimes is not easy to pass because suprapubic catheter is passed via a blind technique or an open technique, because sometimes these pelvic fractures are associated with a lot of pelvic hematomas, and passing a suprapubic catheter can be dangerous. But yet definitely you need a urology consult, and a urologist should know all these things before passing and attempting a suprapubic catheter. If you cannot pass a suprapubic catheter by a blind technique, you need to pass it via an open surgical procedure. Regarding an operative repair, then and there at the time of passing a suprapubic catheter is a debate. So usually nowadays we do not do any operative repair immediately. We just pass a suprapubic catheter and wait for the urethral injury to settle down and go again after 3 months and do an operative repair. So now I talk about bladder injury. So which part of the bladder injury is the weakest and most likely to rupture? We know that there are different parts of bladder: trigon, lateral walls, dome, and posterior wall. So it's very difficult to ask a question here, but I would tell you that dome is the weakest part and is the most likely to rupture in patients who have bladder injuries. Here you can see this a cystogram, and you can see with these red arrow is showing that the contrast is leaking from the dome of the bladder, and it's going in intraperitoneally in between the small bowel loops. 80% of bladder injuries are associated with pelvic fractures. So injuries are classified according to these CT findings, and that can be classified as contusions. It can be classified as intraperitoneal ruptures through the dome. The picture I already shown it to you, and there can be extraperitoneal ruptures that is seen exclusively with pelvic fractures. One thing I need to mention, intraperitoneal ruptures through the dome mainly occur in a patient with blunt abdominal trauma who has full bladder at the time of his injury. So you can always clear in your minds when you take a proper history. If the patient says that I had a full bladder at the time of trauma, so you should suspect that probably he must be suffering from an intraperitoneal rupture. While extraperitoneal ruptures, as I already told you, is seen exclusively with pelvic fractures. So what are the signs? Again, we have gross hematuria in 95% of cases, and we have microscopic hematuria with a pelvic fracture. If there is no pelvic fracture, no gross hematuria, that excludes the bladder injury. What about if the patient has pelvic fracture and a microscopic hematuria? So how do we confirm? Today we have a modality of X-ray cystogram, or we can do a CT cystogram. Nowadays we have switched over to CT cystogram because that also gives us a proper outline of the pelvic bones also. So retrograde cystography is a better modality and is a very sensitive in picking up the bladder injuries. You can see here, this is a CT cystogram of the patient, and you can see a well outlined urinary bladder, but there is a rupture of the bladder from the dome. So the contrast is leaking outside the bladder. So how do we manage? Obviously, if there is contusion, we don't do anything, and that is managed conservatively, and a lot of bladder contusions go undiagnosed also. So regarding the intraperitoneal ruptures, obviously we need to explore, we need to do a laparotomy, and we need to do an operative repair of the site from where the rupture has occurred. And depending on the size of the bladder rupture, we pass a Foley catheter and as well as a suprapubic catheter if required. Regarding extraperitoneal ruptures, many of them can be managed non-operatively with an indwelling Foley catheter, and usually after indwelling catheter of around 2 weeks, majority of the extraperitoneal perforations heal. But again, we need to see if the extraperitoneal rupture is more than 2 centimeters, if the bladder is associated with very much shattered pelvic fracture, then these extraperitoneal ruptures do not heal. In that case, we need to switch over to a surgical operative repair. But yes, initially we manage these patients conservatively, and then we see if the patient is not having a proper healing process, and that the patient is having pain, or the patient on after doing a cystogram at 2 weeks again show the sign of leakage, then we need to go for operative repair. Ureteral injury is an extremely rare pathology which we come across as urologists, but most of the time it is seen in patients with gunshot injuries, it's usually associated or a retrograde diagnosis is made. uh, if we have a suspicion, we do a cystogram. Can you hear me, please? Hello?
जी जी सर सुन सकते हैं.
Okay, there was some problem with my internet. That's why I was asking.
सर होता है.
Okay, so usually a retrograde diagnosis is made via a cystogram, and a retrograde catheter is passed, and then a contrast is injected, and the films are taken through a C-arm, and then the diagnosis of ureteral injury is made. Urine analysis is normal 25% of the time, and we do not have to rely on this finding. So if we have a suspicion, the diagnosis can be made on delay.
यार आवाज आ रही है. Sir, audio issue again, sir.
With IV contrast, have a transected segment, and
Hello.
सर प्लीज अपना माइक अनम्यूट कर लीजिए. सर लेफ्ट साइड पे ऑप्शन होगा अनम्यूट का माइक का, उसको प्लीज अनम्यूट करना. लेफ्ट साइड पे आपका माइक का ऑप्शन आ रहा होगा. सर अनम्यूट लिखा होगा लेफ्ट साइड पे, लोअर लेफ्ट कॉर्नर पे. अनम्यूट पे क्लिक कर दें प्लीज.
%90 of the renal injuries are non-trauma, and 10% are penetrating. So obviously, again, we need to relax and see majority of these trauma patients do not suffer from renal injuries, again because of the lower thoracic cage. This is preventing from renal injuries in most cases. Right. So if you see at this picture, this is showing how the renal injuries are classified. The grade 1, 2, 3, 4, and 5. This is very important because we need to design our intervention according to these grades of injury. Grade 1 injury is classified as contusion, and you can see this black area over the cortical cortex, upper cortex of the kidney, and this represents a hematoma. Grade 2 injury is the one with a laceration, a small laceration on the middle pole is going inside, the laceration less than 1 centimeter associated with perinephric hematoma. Grade 3, when the laceration involves more than 1 centimeter with perinephric hematoma. 4 is the laceration involving the whole of the cortex and medulla, and sometimes there is associated pedicle injury associated with lacerations of the pedicle and hematoma around the pedicle. And grade 5 is totally shattered or multiple lacerations involving the whole of the cortex and the medulla associated with shattered or pedicle loss. So again, hematuria and renal injuries, there is very poor correlation, and that depends on the degree of injury. Microscopic hematuria on its own is not a concern. We need to repeat urine analysis in 3 weeks' time. So which patients require imaging if we are suspecting a renal injury? Those patients with microscopic hematuria with shock, with an ongoing shock, cross hematuria, rapid deceleration without hematuria or shock, or penetrating trauma in the region. So what imaging study usually we do? Nowadays, in this computerized era, we always do a CT scan with IV contrast, and that has roughly around 90 to 100% sensitivity. There is another modality which is commonly used in urology is CT pyelogram or CTKUB, that is actually without contrast. We don't need to do that CTKUB, which is routinely done in urology practice. That is basically done to pick up the stone pathology. So here, to grade renal injuries, we need to do CT scan abdomen with IV contrast. Just remember this fast ultrasound, which is very routinely done in patients with abdominal trauma, is not good for any solid organ injury. So we do not have to rely on this fast ultrasound. And obviously the formal ultrasound is not as sensitive as CT scan. So in patients with renal injury, in a patient who is hemodynamically stable, we need to grade those injury. This is the classification which I just showed, and this is all picked up on CT scan with IV contrast. So after doing a CT IV contrast, we come with the diagnosis that which type of injury these patients are suffering from, and then we manage those injuries accordingly. So if how do we manage? If no rapid deceleration mechanism and no gross hematuria, we can easily and safely discharge the patient home with the follow-up with urine analysis. While in patients who have hematuria and who undergo CT scan, we need to see the grade of the injury. So this is where our management depends on these grades. Grade 1 and grade 2 injuries are actually non-operative management. So the non-operative management usually means bed rest with certain medications for pain relief, and we need to monitor the hematuria, which usually settles with time. So grade 1 and grade 2 injuries are totally non-operative, while grade 3, 4, and 5, basically decision depends on the unit with which you are working at. But usually nowadays, we are managing grade 3 and 4 with very conservatively nowadays also with good results. Yes, sometimes grade 4 injuries in which I'll go back to the same slide again. In grade 4 injuries, there is sometimes a urinary leak and the patients can present with urinomas, and sometimes these patients do require a DJ stenting, which is done through a cystoscope, via a cystoscope under general anesthesia, or they do require a pigtail catheter to be inserted into this hematoma to drain the urine that is leaking out of the kidney and collecting in the perinephric space. So this is all conservative management, and majority of the patients do get better with this approach also. We do not usually nowadays jump to surgical intervention even in grade 4 injuries because if we go for surgical intervention, we have no choice but to do nephrectomy. So in order to save the kidney, we just do these minimally invasive procedures, pass a DJ stent if required, and do a pigtail insertion percutaneously under ultrasound guidance. Majority of the patients get better, and basically the injury site actually heals by fibrosis, so that area undergoes scarring and that becomes non-functional, but rest of the kidney functions normally. While in case of grade 5 injury, you can see in this picture, grade 5, the kidney is shattered from all around and the pedicle sometimes goes away. There is no vascular or blood supply to the kidney. In that case, we have no choice and we have to do nephrectomy. Right? So, any questions? Can I open, unmute? Makas?
Yes, sir, you can. The students can raise their hands also.
Yes, how do I check?
सर देखिए जैसे मेरे नाम के आगे कुछ आ रहा होगा, वकास के नाम के आगे एक हैंड बना हुआ आ रहा होगा। सर इसी तरह स्टूडेंट, जी सर, अगर इसी तरह स्टूडेंट भी अपना हैंड रेज कर सकते हैं तो आप उनका माइक फिर अनम्यूट कर सकते हैं।
सब जाग रहे हैं ना?
और सर आप अनम्यूट ऑल भी कर सकते हैं अगर डिस्कशन करनी है।
ठीक है, म्यूट ऑन कर दिया मैंने।
ओके।
Okay, is there any question?